So FSHD research, it's really at an inflection point, and some of you may have seen this slide before, but it's kind of a mix of a timeline for FSHD along with scientific publications. And I think the first thing you're going to notice, these blue bars represent the number of scientific publications per year. The right is the past, the left side is today. And you can just see that the number of scientific publications are increasing, you know, and so over time, as we're learning more about FSHD, it's bringing more people to the field, and we're getting more scientific, explorations. You can see here we have the discovery of the deletion that causes FSHD back in 1992. This was followed by a natural history study and then a number of clinical trials right around the 2000. Then really in 2010, there was a major turning point. And this was the publication of the unified model for FSHD, which identified DUX4 as the cause of the damage. And this really changed the kind of questions that researchers were asking, from what causes FSHD to really how can we start treating or curing FSHD. And you can see there was a large increase in publications after that because many new people were coming to the field. Another really important event has been the development of animal models as well as other preclinical models to test new therapeutics. And we're going to hear about that today because that makes possible what everyone's really interested in, which is new therapies. And the ones in green here, these are clinical trials that are going on currently. That includes the Fulcrum study as well as our Resolve trial preparedness study. It has been a busy year. I'm just pulling headlines. These were in the press, maybe not the New York Times, but a lot of the scientific press. And you can see we had Acceleron, who announced the results of a phase 2 study in FSHD this year. We had Dyne Therapeutics, who publicly announced they now have a research program in FSHD, which is quite exciting. They have a RNA-based therapeutic that would be a gene therapy. They're also supporting our natural history study. We have the FSHD Society gave us money to help us expand our network in the United States so we could have 12 sites participating in research with us. And of course, Fulcrum, who has a clinical trial that started and they've completely filled it over the course of the last year. And I'm going to talk more about the Acceleron and Fulcrum studies later, but hanging over all of this, of course, in all of our lives is COVID. You know, in the same way this has affected much of what we do, this has also affected research. And so we've had to adapt. But what I'd say is I still think it's a very hopeful time because we and the companies doing this research are really committed to continuing the FSHD research mission during the COVID pandemic. And I think to a large part, that's been true. What I want to do now is I want to pause for a minute and hear from Mark Stone. He's going to give some introductions. The FSHD Society has helped us out a great deal as we put this together. And so, Mark, I'm gonna turn it over to you for some remarks.
Great, thank you, Jeff, and thank you really to you and your team and Peter Jones. When professionals give up a Saturday for our families, I'm both humbled and overwhelmed with appreciation. And so I wanted to express that right from the get-go. And I want to thank all of you who've tuned in. By you tuning in, it says that not only is this important to you, but you want to be a part of the solution. You want to be a part of something that is world-changing, not just life-changing, for almost 1 million people worldwide. It's been said that people working together in a strong community with a shared goal and a common purpose can make the impossible possible. I'm going to run down in just hopefully a minute or a minute and a half. We've gone on record. We've actually posted it. We put a pin in the calendar, as I like to say, that we want to have therapies, safe and effective therapies to our families by 2025. And I've been criticized by that because there's a lot of things that are out of any one person's control in that. It just is. And so somebody has said, is that just an aspirational dream, which is okay, or is it really an achievable goal? And Dr. Statland really set my very quick rundown through a little list that I just created for this day and for others by going over that timeline. We are moving forward confidently as the FSHD community worldwide for these reasons, in my opinion. First, we have a discovered cause. I've always said if you know the cause, you can perhaps find a cure. And the good news is, and it is good news, it's a monogenetic disease, one gene. And there's been success like this in other muscle disease areas. And so we have a discovered cause. We have a tested strategy. There are 2 to 3 dozen research-focused patient advocacy organizations like ours that essentially have developed a formula for expediting therapies to the market once their research has brought them to a point. And our research, I believe, has brought us to a point. We have a focused plan. There's stakeholder consensus on obstacles that we need to eliminate to move forward, and we're collaborating on those globally. We have aggressive timelines. I think 2025 is very aggressive. Somebody says 5 years. That's lightning speed in getting therapies to our families. But we're hopeful, and we're working toward that. We have an experienced and passionate team. We have a team of volunteer leaders. Kylie, while she is on staff there, she's also our chapter director here in the greater Kansas City area, and she becomes one of those people. Many of our doctors are also our volunteers and our volunteer leaders. We have literally an army of activists that can change the world. Indeed, it's the only thing that ever has. And finally, I believe we have a purposeful path. We've hosted an industry collaborative with the FDA and the NIH and research teams from pharmaceuticals and clinicians and researchers. And we've kind of begun to focus on and agreed upon a path the obstacles that we need to eliminate. Many of our researchers and clinicians, present company included, are working on what I call obstacle elimination projects. And we're focused on those and empowering those. We have an empowered community. And I think most of all, and most importantly, is we have a network, the Clinical Trial Research Network for FSHD, which is the coordinating center is at KU Med Center. And Dr. Statland is the global leader in that, along with Dr. Tawil. And through that infrastructure, through that network, I believe that's why we've seen so much progress. And Dr. Statland's timeline that has gone up, I give 80 to 85% even more credit to this core facility, this core network and infrastructure for really moving it forward. Now, that doesn't take anything away from families that have volunteered for the RESOLVE study. It's everybody wants to be in a study where there's a therapy. I mean, you have sign-ups and how can I get in and all of that. But we would not be here at this moment in history if it wasn't for many of you that said, listen, I'll sign up for the RESOLVE study. I'll let you observe me over time. And through that observation, pharmaceuticals, as many as a dozen of them, I think, are now willing to look at our space, to consider therapies, and to consider moving forward, primarily because of the Clinical Trial Research Network, Dr. Statland and Tawil's work, and because you signed up and you showed up, and you're moving forward with that RESOLVE study that's going to show, I believe, a natural history that we can take into therapeutic development. So thank you all for showing up today. Thank you for showing up each and every time you've shown up. Those of you in the Resolve study and the Fulcrum study and the Acceleron ACE83 study and all of those, you are indispensable. And together, we're changing the world. We really are, for everyone with FSHD. So thank you. I'm going to hand it back now to Dr. Statland. And this is a fabulous lineup, and I hope you enjoyed the day.
All right. Thank you so much, Mark. We appreciate those words. So I get the fun task. So I get to start off the day of science. What I'm going to do now is really a high-level overview of FSHD in the genetics. The purpose here is to kind of set the stage for some of the talks that you'll be hearing after mine. And so when we think about FSHD, this is a disorder. It was really first described by these French researchers in the late 1800s, and what they had described was a condition that was inherited, that it showed people who had wasting of the muscles affecting the face, shoulder, and arms. And then really, I think one of the next key points in terms of our understanding of the clinical side of the disease came from a Dutch researcher, George Padberg. Some of you may have had the luck to hear him speak. He's a fantastic speaker. But he did a really seminal work as part of a doctoral thesis. So for those of you who don't know, that means he was still in training when he did this. And he just traveled around the Netherlands, which is where he lived. He found these families with FSHD, and he very systematically described what he saw. And our current notion of FSHD really came out of this work, and we still refer to it. He showed the patterns of clinical presentation, the asymmetry that we see, and some of the other rare features like hearing loss or problems with the eyes that we occasionally see. When we think about FSHD, there are two types. So there's two genetically distinct types of FSHD. Over 95% of people, though, will have FSHD1, and clinically they really look the same. You can see the sort of classic muscles affected highlighted in this cartoon. And while we do see this on the whole initial pattern of involvement, some of you may know from your own experience and MRI studies where we look individually at muscles have suggested that actually it doesn't exactly follow this pattern, because some of these more proximal muscles in the hip and around the back, they can actually be affected quite early. It is a dystrophy that affects people all the way from birth through old age. I have people getting diagnosed throughout the lifespan. There's considerable variability. This can be between individuals who have the same mutation, between family members from one generation to the next, or even within a single person from one side of their body to the other. We don't really see heart disease that's specific to FSHD. In dystrophies, we're always concerned about the heart and the lungs. However, we do see some respiratory involvement. People can get to where it's hard to take a deep breath. Most commonly, we see this following weakness. So as people are having difficulty walking, or if they're really having a lot of weakness in their core, we'll start to look for this more carefully. There is a more severe form of FSHD affecting children, often starting before the age of 5 with weakness before the age of 10. We see these other than muscle manifestations in these patients, the problems with the eye or hearing more frequently, but overall this is not a frequent event. It's about 10% of individuals, and on average it's slowly progressive. You'll hear people quote 20% of people over 50 may require the use of a wheelchair. When we think about the clinical features, I've just illustrated some here, and now if any of you who are in the pictures are on today, thank you very much for agreeing to allow us to do this. But in the first one, you can see this very characteristic. As the shoulders become weak, they kind of drop down and rotate forward. You can see the change in the bone, the clavicle, as it flattens out. You can see wasting of the pectoral muscles with this increased crease around the armpit. In the back here, you can see winging of the scapula. They're sticking out. In order to lift your arms above your head, the muscles have to pin that scapula against the chest wall. but you can also see it's asymmetric, so a difference from side to side. In this individual, I think you can see their left leg, it really looks fairly normal, but you can see in the right leg, there's clear wasting of two muscles that are quite commonly affected, the tibialis anterior and the medial portion of the gastroc. Here you can see the facial weakness. I've asked someone to try to pucker their lips into a tight purse string, and you can see that they're unable to do it, and there's some asymmetry in this. And here you see a very characteristic appearance around the shoulder as someone tries to lift their arm. This actually has a name. It's called the Pauly-Hill sign. What you're seeing in the blue arrow is actually the scapula riding up above the level of the shoulder from behind. Here you're seeing part of the shoulder joint that normally would have a muscle overlying it, so you wouldn't see it. And here you see the distal part of the deltoid that's usually preserved until quite late in FSHD. When we think about the genetics, I'll just say FSHD is a challenging disease even for people who know genetics, but you can think about it in more simplistic terms. What we have is a gene called DUX4 that's normally turned off, and it's getting turned on in FSHD, and the product of that protein is toxic to muscles. You just see a muscle here. The green is a muscle fiber. The blue are the nuclei. That pink color is DUX4. For those of you who don't really remember genetics from your days in biology, we're made up of cells. We have 15 trillion cells in the body. The cells make up everything of who we are, our skin, all our organs. Inside of each cell, there's a nerve center, the nucleus, and inside the nucleus, we have chromosomes. We get one set from each parent, so we have 46, 23 come from each. They contain the instructions that help us make all those proteins that make up who we are. And each of those chromosomes are made up of DNA. You can think of DNA as the recipe. It's telling the cell what to actually make. And so I'm going to take a metaphor here and I'm going to stretch it. And it's a metaphor for cooking. We can think of all the DNA we have being contained in a library. That library is contained in the nucleus. Each of those chromosomes I talked about is a cookbook. And inside that cookbook are recipes. This is the DNA, the code on the DNA, which tells us how to make proteins. In a normal situation, we have a runner, we call it RNA, that carries the recipe out to the kitchen, which is the cytoplasm of the cell where the proteins are made. So what do we have happening in FSHD? I told you back in the 90s that we had actually determined that a deletion was causing the disease. This is a cartoon illustration of the long arm here of chromosome 4. You can see a region we call the D4Z4 region. There's several repeats. They're quite large, many thousands of lines of that recipe large. Normally, people have more than 10 of these repeats. In FSHD, there's a deletion where people are left with between 1 and 10. So how does this cause the disease? Well, this is again that cartoon illustration of that region on chromosome 4. Normally, if we think of this as a cookbook, this part of chromosome 4 is still shrink wrapped in plastic, like a book you just get from the store. You can't open it up. You can't read the recipes inside. Chemically, the way the cell does that is methylating this region. That keeps it shrink wrapped in plastic. We can't open it up and read what's inside. In FSHD, a deletion of those repeated units has the effect of lowering that methylation, but what that would be like is you ripping the plastic wrap off the cookbook. So when you have that decreased methylation, the chromosome opens up, we take the plastic wrap off the cookbook, and now we can read the recipes inside. Contained inside that is the recipe for one gene, DUX4, and this gene is a transcription factor. It activates many of hundreds of other genes, and when it does that in an adult cell, it's highly toxic and it causes damage to the cells. So this is the unified model that I talked about. Whether we're talking about FSHD 1 or 2, the first thing that has to happen is you have to rip the plastic wrap off the cookbook. In type 1, it's due to deletion of repeated units. In type 2, there's other genes that have a role of putting the plastic wrap on. And so for FSHD2, they have a mutation in a gene that its role is to methylate this region. It opens up the chromosome, but there's one last step. The recipe for DUX4 is missing the last line, the line that says cook until done. Certain people have what's called a polymorphism. This is just a naturally occurring variation in a chromosome that supplies that last line of the recipe. So the two things we need to make DUX4, ripping that plastic wrap off the cookbook, so decreased methylation, and then that permissive polymorphism, the change in the DNA that adds that last piece of the recipe, and that allows the cell to make DUX4. Now, a lot of people hear me say something like this, and then they get very confused when they look at their genetic test reports, because what they see on their genetic test reports is something very different. They see something that's kilobases, and they go, well, how do I know how many repeats I have if this test is telling me kilobases? The test that's most commonly used for FSHD is called the Southern blot, and I'm just going to walk us through it a little bit here so people can understand it. It's a test that basically cuts out that region on chromosome 4 and just measures how big it is. When we think about diagnostic tests, we always want to know things about sensitivity and specificity. Sensitivity means a test appropriately diagnoses someone if they really have FSHD. Specificity says it doesn't diagnose them as having it if they don't. We want those percentages to be high. Our common test right now has a sensitivity of about 93% and a specificity up to 98%, but only if someone clinically looks like they have FSHD. To do a Southern blot test, it requires blood. We get DNA, which comes out of certain types of blood cells that we can isolate it from. They use something called restriction enzymes, and I'll come back to this on the next slide, to cut out this region. We use something called a Southern blot to measure how big it is, and then you end up with something that's a size, and they do it in kilobases, but it's essentially a weight for the region. Normal people have more than 38 kilobases. In FSHD, there's between 10 and 38. In order to cut out a region of DNA, we have to have a tool to do it. It's a pretty amazing story because we take enzymes that come out of bacteria. Bacteria, it turns out, just have naturally occurring enzymes to attack foreign DNA, and they recognize different regions of the chromosome. And so we've picked two of these restriction enzymes that really recognize the region we're most interested in on chromosome 4, and they cut that region out. We then take those pieces and we put them on something called a Southern blot. You apply electricity to it. It turns out pieces of DNA have little positive and negative charges on it, and how far it moves on that blotted paper has to do with how big it is. And so depending on how far it goes, we can make an estimate of how large that repeat is. And there is an association between the size in kilobases and the number of repeats. And if you're wanting to do this on your own genetic test report, there's a simple mathematic equation you can do to do it. You can subtract 6 from your number and divide it by 3, and you'll roughly get the number of repeats here. And you can see there's really a pretty good correlation between the size here on the y-axis in kilobases and those number of repeats that you see, with some slight regions where there may be overlap. So it's not 100% precise. This is just an example of someone's actual DNA report to show you kind of how you read it. The first part is that restriction enzyme I told you about. It cuts out the D4Z4 region. You can see here, one of those is 24 kilobases, so the size that we would see in FSHD, and by that formula I told you about, you would get about 5 repeats. There's another restriction enzyme because there's an area on chromosome 10 that also has repeated units, and this other enzyme can help us tell the difference between them two. And then the last thing they do is use a probe that will tell us which one has that permissive polymorphism or not. And so this person would have a positive test. Their fragment was 24 kilobases, and it was on a permissive polymorphism. So what I want to do now is pause, and I'm happy to take any questions before we go on to the next speaker. Are there any questions?
Yeah, I'm Gary Caller. I'm here in Colorado. I've had this condition since my probably mid to late 30s. I was just wondering, you know, where you guys are at with like replacing a whole gene, the DUX4 gene. Is there any work being done in that regard? Is that feasible even?
Yeah, Gary, I mean, that's a great question. And FSHD is a little different. We're not wanting to replace it. What we really want to do is turn it off. And yeah, there's a tremendous amount of work that's going into doing that. In fact, you're going to hear quite a bit about it today. I think Peter Jones, that'll probably be part of what he's talking about. I'll return to it again a little later as well in a talk, but there's a number of companies and strategies to try to figure out how to do it. Indeed, the Fulcrum trial going on right now has a drug where they think its target is turning off this gene.
Okay. Thanks.